I'd like to quickly review where we were. We went through several explanations, maybe 7, 8, I forget the exact count, of those that, when looked at closely, we interpret as consoling explanations. Explanations that made us feel better, but that also avoided a hard look at what was really the core set of issues about the American system that keeps us the outlier by international comparison. Outlier in both the metaphoric sense that we're way out in left field somewhere, in that usually general and subjective way in which the term is used, but also outlier in a more specific, quantitative, statistically meaningful sense in which we are literally, as I showed you on those graphs in the handout, we are literally the statistical outlier as well in terms of how much we spend on healthcare. And after going through and essentially dismissing, if not completely ignoring, as consoling explanations that don't tell the real story or don't tell the major part of the story, we were left with 2 possible explanations which I call the R explanations, the residual explanations that are left after dealing with the consoling explanation, or if you like, the real explanations for why the United States is so much the outlier in terms of its healthcare spending. And those 2 residual or real explanations I would summarize now this way. One is the absence of a true functioning market, which means the absence of transparency about prices, which therefore doesn't really allow consumer decisions about prices because they are opaque and not accessible, and therefore no simple market response, supply and demand and the like. There's something funny, peculiar, rigged about the healthcare market in the United States. That isn't the case where there are either well-regulated markets or where there is a true open market, which we do not have. And the second reason is that because we have a poorly regulated, multi-payer system, we have excess and very high administrative costs that are associated with that excessive complexity and wastefulness. We have very high administrative costs in addition to the imperfections of our market. So let me deal with these in turn. First, the imperfect market. Instead of having a market and a real pricing system based on clear information and true competition, we have an elaborate scam. I don't think there's any other way to put it. That almost everyone involved, including physicians, feel helpless about. Those who run the scam are a collusion, as I see it, of hospital administrators and insurance companies. They're in it together. But physicians who have to survive in the system often feel helpless and apologetic about what goes on, and they have very little, if any, control over it. This scam was well known to smart health economists and policy wonks for quite some time. If you look in some of the best journals and read some of the leading authors, you will find articles like this more than a decade ago. Here's an article by Uwe Reinhardt, and we're going to come back to this name several times. He is one of the heroes of T.R. Reid, one of the people T.R. Reid learns from when he is a postdoctoral fellow, when he is doing a visiting position at Princeton in the Woodrow Wilson School. Reinhardt is a world-famous, very respected, German-born, Canadian-educated, American-working health economist and policymaker who is one of the smartest and actually one of the cleverest and funniest people in the field. He published in 2006 an article in the very respected journal Health Affairs. One of my students asked me if Health Affairs would be a respectable journal, and my answer was, oh yes, Health Affairs is probably, for health policy, the most respected journal, at least in terms of those who are influenced by it. It is not only respected by health economists and policy analysts in the field, it is deeply respected in Washington. It's the journal within the Beltway that's most deeply respected, not least because the editorial offices are on DuPont Circle in Washington, but that's only part of the reason. If you read it in Health Affairs, you know it's been very carefully peer-reviewed and is top-of-the-line analysis. So in 2006, Uwe Reinhardt, PhD from Princeton, by the way, PhD, published an article called "The Pricing of U.S. Hospital Services, Chaos Behind the Veil of Secrecy." And here is the first part of his abstract, so you get a flavor of what Reinhardt is driving at. He writes, "Although Americans and foreigners alike tend to think of the U.S. healthcare system as being a market-driven system, the prices actually paid for healthcare goods and services in that system have remained remarkably opaque. This paper describes how U.S. hospitals price their services to the various third-party payers and self-paying patients." And then in the core of the article, I'll just read you a couple of additional passages, and you'll pick up the flavor of Reinhardt's brilliant analysis and general cleverness and really a very penetrating sense of humor. He identifies right up, very early in the article, the hospital charge master. Until this time, not many people, even in the policy community, were well aware of the charge master or of its significance and the way it operated. But Reinhardt made it front and center, and it's been front and center ever since. The hospital's charge master. Overarching the U.S. hospital system is each individual hospital's, quote, charge master. A hospital's charge master is a lengthy list of the hospital's prices for every single procedure performed in the hospital and for every supply item used during those procedures. A sample charge master posted on the website of California's state government, which is one, he points, of the more transparent sources of information about charge masters that's required in California, or at least it was then. That posting includes 20,000 items, each with a particular price. What that price reflects is another story. Hospitals do not follow a common practice in updating their charge masters. Some hospitals might simply raise every price on the list by the same percentage once a year. Others might update prices for particular items or procedures separately by different percentages, which makes it difficult to know by what overall percentage a hospital has increased its prices. These updates sometimes occur more than once a year. In general, the process appears to be ad hoc. That is, there's no rationale other than how can we work the system to get maximum return for the hospital. And he also has the following typical Reinhardtian passage in which he says something quite penetrating and brilliant, but puts it in a very accessible way that will make you smile and make you grimace at the same time. He says, on page 64 of that article, "Until now, the U.S. healthcare market has been analogous to an imaginary world in which, say, employers offered to reimburse their employees 80% of the reasonable cost, quote-unquote reasonable cost, of all attire deemed necessary and appropriate on the job. But," he's using an analogy, "under the contracts negotiated with department stores by the fiscal intermediaries administering the closed benefit program." So he's making an analogy to health benefit program and an imaginary closed benefit program that companies might employ. This is what really happens. According to the closed benefit program, and think of how apt this analogy is to the healthcare system, employees enter department stores blindfolded. Only months after the shopping trip would the employee receive from the fiscal intermediary a so-called EOB, explanation of benefits, explaining how much the employee had to pay for whatever he or she had stuffed, blindfolded, into the shopping cart on that shopping trip. Yes, that's what healthcare is like from us consumers. We are blindfolded, we have no idea what we're purchasing, but we have this guarantee of 80% coverage, whatever, and this is worked out in a collusion between the insurance companies and the hospitals and their charge masters. That was for essentially a policy audience, and some of them began to talk about it a lot, grumble about it, but it didn't really become a public issue until the very, very competent investigative reporter, Stephen Brill, got very interested in this problem and began to look into it. He was working on a book which was published to great acclaim in 2015 called The Bitter Pill. And that was reviewed immediately, as I pointed out last time, by Lancet, the internationally respected medical journal published in England, in which the book is given high praise and said to explain things about the American system that most people have been baffled by. Time magazine heard about this book, knew it was going to be a terribly important event, and gave Brill an entire issue. This is the March 4th, 2013 issue, to essentially present a preview of the book. So it's America's Bitter Pill, Why Medical Bills Are Killing Us. That's what it looked like. And then let me just read you from the Xerox version of that. I didn't want to mark up my pristine copy of Time magazine with some of what Brill has to say, which is essentially the same message as Reinhardt, but in much more accessible and explosive terms. He has a little section called the $21,000 heartburn bill. That is bill that you receive to pay. One night last summer at our home near Stamford, Connecticut, a 64-year-old former clerk, whom I'll call Janice S., felt chest pains. She was taken 4 miles by ambulance to the emergency room at Stamford Hospital, officially a non-profit institution. About 3 hours of tests and some brief encounters with a doctor later, she was told that she had indigestion and was sent home. This was good news, but the bad news was the bill. $995 for the ambulance ride, $3,000 for the doctors, and $17,000 for the hospitals, in sum $21,000 for a false alarm. Out of work for a year, Janice S. had no insurance. Among the hospital's charges were 3 troponin 1 tests at $199.50 each. According to the National Institutes of Health website, a troponin test, quote, measures the levels of certain proteins in the blood whose release from the heart is a strong indicator of heart attack. It's a good test. How much does it really cost to run? Stanford Hospital spokesman told me that the $199.50 figure for the troponin test was taken from what he called the hospital's charge master. The charge master, I learned, is every hospital's internal price list. Decades ago, it was a document the size of a phone book. Now it is a massive computer file, thousands of items long, maintained by every hospital. It turns out that Medicare would have paid Stanford $13.94 for the troponin test that it billed Janice S. for $199.50. In the minds of the hospital administrators, Medicare is not paying enough. In the minds of the Medicare analysts, $13.90 is very generous because when you look at what actual reagents were needed, what processes and what amount of labor, $13.90 was overpricing it a bit. And for that, the hospital charged and got away with charging when it wasn't having to run the rigorous tests of Medicare evaluators, $199.50. Janice S. was also charged $157.61 for a CBC. That's a complete blood count. Medicare pays $11.02 for a CBC in Connecticut. Hospital administrator, much too low. Medicare, we're being generous. How much does it actually cost you to run that thing? Don't scam us. We're watching you. According to the hospital's latest filing, its total expense for laboratory work like Janice S.'s blood tests in the 12 months covered was $27.5 million. That's costs in labor for the technicians who ran it, costs in materials, whatever was necessary to collect it, etc. It charged for what it cost, 27.5, what it had to actually pay for, 27.5 million. It charged and collected 293.2 million. That's a more than tenfold inflation. And got away with it. It's a scam. There's no other word for it. That means it charged about 11 times its costs. As we examine other bills, we see that Medicare patients, the large part of hospital patients who, that except for Medicare patients, the large portion of hospital patients with private insurance get discounts off their listed chargemaster figures, assuming the hospital insurance company have negotiated to include the hospital in the insurer's network and so on. But even with the discounted insurance company rates, there are sufficient profits at these officially non-profit hospitals. Those profits are further boosted by payments from the tens of millions of patients who, like the unemployed Janice S., have no insurance or whose insurance does not apply because the patient has exceeded coverage limits. Those patients are asked to pay the full chargemaster prices. If you are confused by the notion that those least able to pay are the ones singled out to pay the highest rates, welcome to the American healthcare market. Real, residual, undeniable out there. Let me just read another passage from the Brill article to drive the point home. As soon as I find the paper. Okay. Brill writes, the healthcare market is not a market at all. It is a crapshoot. People fare differently according to the circumstances. To circumstances they can neither control nor predict. They may have no insurance. They may have insurance, but their employer chooses their insurance plan, and it may have a payroll limit or a payout limit or not cover a drug or treatment they need. They may or may not be old enough to be on Medicare, or given the different standards in the 50 states, be poor enough to be on Medicaid. If they're protected only partly by private insurance with high copays, they have little visibility into pricing, let alone any control of it. They have little choice of hospitals or the services they are billed for, even if they somehow know the prices before they are billed for the services. They have no idea what their bills mean, and those who maintain the charge masters couldn't explain them if they wanted to, and they don't want to. They have no choice of the drugs that they have to buy or the lab tests or CT scans they have to get, and they would not know what to do if they had a choice. They are powerless buyers in a seller's market where the only sure thing is the profit of the sellers. And then it goes on to explain why Medicare is much more efficient than these private companies, and instead of deriding Medicare and its low bowling, maybe we should praise Medicare for its rigor, accuracy, and toughness. Put simply, the bills that we get from hospitals tell us that this is not about interfering in a free market. It's about facing the reality that our largest consumer product by far, 1/5 of our economy, does not operate in a free market. Okay? So I think that makes the point, perhaps overmakes the point, that one of the real factors explaining the U.S. outlier status is the absence of a true market, a free market. Instead, there's a rigged market, a crapshoot, whatever you want to call it, that operates in the reality of billing, pricing, profit making, and so on. And the issue didn't just become a journalistic sensation and go away. health economists and policy analysts kept returning to this issue. And here, as an example of that, another article from Health Affairs, remember, very, very high standards, very deeply respected. An article by two economists from the Bloomberg School of Public Health in Baltimore, known as Johns Hopkins School of Public Health, not a mere piece of cream cheese. This is serious stuff. U.S. hospitals are still using charge master markups to maximize revenues. 2016 publication in Health Affairs, which means it is still going on, obviously. Second basic reason why our system is such an outlier is because we have a very poorly regulated, very inefficient, very expensive, multi-payer system which multiplies administrative costs beyond any rational need. We have several places where she and Singh discuss this. Let me just point to a couple, and then we'll need to move on in the interest of time. So if you look at page 475, where she and Singh discuss the various factors contributing to U.S. healthcare excess, they talk about multi-payer systems and administrative costs, beginning in the left column on that page and continuing top of the right column. And let me just, you can read the whole thing, you should read the whole thing several times. Let me just pick a few phrases from that to give you the flavor. Each activity in our system has associated costs. Private insurers also incur marketing costs to promote and sell their products, their plans. Providers have to deal with numerous plans, not just one plan or two plans. They have dozens and dozens of plans, each with different payment schemes. So this requires additional personnel, additional administrative time. Numerous plans in which the extent of benefits and reimbursement is not standardized. It is difficult and costly to remain current with the numerous and changing rules and regulations, et cetera, and then all this requires extra personnel, extra cost, extra expense, and that's why we have, according to the best analyses, somewhere between 12 and 20% on average administrative costs associated with just administering third-party reimbursement in the private market. That compares to a figure of somewhere between 1 and 3% for Medicare. So if you have the illusion that government programs are inefficient and bloated, why don't you consider a trim, let's say 2%, versus a bloated 12 to 20%. And all that is extra money that is not going to patient care. That is money that's going into overhead and profit and marketing and all the rest of it. And then another place where you can just get a feel for what our multi-payer system is like and how it operates, look back to the beginning of the book on page 5, where the authors write that what we have is a system that is functionally fragmented and the various system components fit together only loosely. Such a system is not subject to overall planning, direction, and coordination. Duplication, overlap, inadequacy, and inconsistency, plus waste exist. The system as a whole does not lend itself to standard budgetary methods of cost control. Each individual and corporate entity within a predominantly private entrepreneurial system seeks to manipulate financial incentives to its own advantage without regard to its impact on the system as a whole. Hence, cost containment remains an elusive goal. In short, the U.S. healthcare system is like a behemoth or an economic megalith that is almost impossible for any single entity to manage or control. The use of language like behemoth, which we know is an extinct mammoth from prehistoric times, or megalith, suggests that our system is woefully out of date, cumbersome, and possibly on its way to extinction, if you take those references from geology and biology literally. But the authors are trying to use powerful language to capture your attention. So those are the two, in my analysis, basic reasons why we have this outlier system in the U.S., the real residual reasons. The question then is, why do things get so bad? And why do we let those who make vast profits at the national expense get away with it? Why? I can come up with three primary reasons. First reason is that we refuse to face reality. And naively, chauvinistically, and fairly, in my view, foolishly, insist that, quote, we have the best system in the world. That's just common sense. End of story. No further discussion. We've got the best system in the world, so we refuse to face the reality. We refuse to see things that are hidden in plain sight. And instead of looking at the two residual factors that really require some serious soul searching and some real political will and courage, we look for consoling explanations, and instead of really getting in and trying to change things in a serious way, we tinker around the edges. We just play at the margins. We avoid what's core because we refuse to admit the reality that we hide in plain sight and deny. It's just common sense that we have the best, most efficient system in the world. It's just common sense that the private market is the most efficient and so on. Look at it. Look at the reality. Look at the data. And then try to say that again. There are two other reasons that I would add to that. And I think these are very important and that we will be getting to now and until the end of Monday. First is that we have a confused system of cultural values and beliefs. We don't have a simple American way. Some people say, but it's not American. Americans think it's private enterprise, blah, blah, blah. In fact, when we look closely, we don't have a consistent view of that kind. We have a muddle, a mixed set of beliefs and values. So we actually have, in reality, a confused and mixed and conflicted set of cultural values and beliefs, and we keep getting tripped up over them because we don't have a consistent set of American values. It depends who you ask, and when you ask it, what is, quote, American or not. There is a very good and succinct discussion about our confused cultural beliefs and the conflicts within them in She and Sing, pages 62 to 68. It's a section that bears very close reading, and I'll highlight a few portions of it in just a moment after I complete my list. I'm going to come back to that. And the second of these two, the third reason why we don't actually understand what the real issues are in the United States, besides having confused and conflicted cultural values and beliefs, is that we have lived through, as a nation, as a culture, a very complex and troubled history in the attempt to achieve something like universal health reform, something that other countries, that European countries began before the turn of the 20th century, that we tried to start at the turn of the 20th century in the first years of 1900s or so. And we have lived through a complex history from that time forward. It's been troubled, it's been difficult, it's been painful, it's been confusing, and we are still trapped in that history, and we are still vulnerable to some of the standard moves that have been made in that history to deflect attention or to achieve certain political ends by using, for example, red baiting tactics and the like. It didn't disappear with the McCarthy era. It didn't start with the McCarthy era in the mid-50s. It's still with us now. Even with our cartoons that tried to blow this away, call something socialized, and a very considerable number of Americans shut their ears and stopped thinking. without realizing how much of our life that we value, like public libraries and public schools, represents socialism in some sense of government doing services, providing things on the basis of general tax contributions so that the community can be served when its needs are pressing. The best place in the textbook to look at some of that history is pages 82 to 108. And I will go through some of those pages in more detail, and I will supplement what's in those pages with handouts. I've already started that today, and with additional readings that are on Blackboard, already posted, to which I will call your attention at the appropriate time. So let me go back to first the confused set of values and cultural assumptions and beliefs. I told you that that's on pages 62 to 68. And what Xi and Singh tell us is that essentially we in America are confused and conflicted because we have two basic models of societal relationships and of societal relationships with regard to healthcare that coexist but that are inconsistent with one another, are often in sharp conflict with one another, and have never really been resolved. There are people who are in one camp and people who are in another camp, and they are often at one another's throats with great antagonism. These two basic models are what Xi and Singh call the social justice model and the market model. And they neatly summarize the essence of these two models in a table, table 2.5 on page 65. It is very closely related to the text that surrounds it, but it's a neat summary table. Just so to give you a flavor of it, you can go through it, should go through it yourself several times. In the market justice model, healthcare is seen as an economic good, whereas in the social justice model, healthcare is seen as a social resource. In the market model, market justice model, the assumption is that free market conditions for health service delivery prevail and are effective, whereas the social justice model requires active government involvement in health service delivery, especially for those who are not well served or are hurt by the market. And so it goes. Look at that table, look at the explanations, realize that these are powerful beliefs that different sets of people in the United States hold deeply, and there is no national consensus. Don't ever say, Americans believe. 73% of Americans believe that, and 24%, etc. There is no one consensual view in the United States. Rather, we have deeply conflicted values, and this, of course, has come out in recent elections and the behavior of our so-called representative institutions, and so on. We don't have an American consensus. We have fundamental American conflict. To amplify some of the reasons that there are justifications for maintaining a social justice model, even in a predominantly market justice culture, look at pages 67, bottom right, and 68. Market justice principles fail to rectify critical human concerns. Pervasive social problems such as crime, illiteracy, and homelessness can significantly weaken the fabric of society. Indeed, the United States has recognized such issues and instituted programs based on social justice to combat the problem. Healthcare is an important social issue because it not only affects human productivity and achievement, top of page 68 left, but also provides basic human dignity. Is every person's dignity important? In my mind it is. In my value system it is. Not always in other people's minds or value system. But there are a significant number of people who agree with me, and that's part of our American reality. Market justice does not always protect the society. Individual health issues can have negative consequences for society because ill health is not always confined to the individual. For example, patients with SARS 2 years ago were turned away by hospitals because they weren't able to pay. That's a simple application of the market justice model. But it doesn't work. It was dangerous. You turn people with SARS, any contagious disease, away from a hospital they can't pay. They give it to everyone else. Is that a smart decision? In whose interest is that? So there are good reasons for being perturbed and confused and conflicted about this. Market justice does not work well in healthcare delivery, the authors say. A growing national economy and prosperity in the past did not materially reduce the number of uninsured Americans. On the other hand, the number of uninsured increases during economic downturns. And so the notion that, well, just improving economic circumstances in general will be a tide that raises all ships doesn't in fact work, doesn't in fact square with empirical realities. So it's these realities and conflicts that make us very, very different from other countries, especially from European countries, from Canada, from Australia, from many places around the world that we admire for many reasons. And this is what T.R. Reid will be getting to when we get to his book very soon, and also view his documentary film that was made out of the materials for that book. We'll get to that. We'll get to that shortly. But I want to get to factor 3 and move with that as quickly as we can so that we can really get to be where we should be at the end of Monday, What I consider the third factor in my list of 3, we are living out the product of our history. Conflicted, often shocking and traumatic, and the unresolved history. It's a history we generally don't know, which makes it all the more powerful. If we don't know it, we can't see it, we can't try to rise above it or stand beside it, we are still engulfed in it. And it's a history marked by conflict, turbulence, ugliness, that we keep repeating without real resolution. And we keep repeating it because, in part, we don't know it. If we knew it and saw it, we might be able to develop some independence from it. The Obama administration clearly believed that we should know our health care reform history. And good evidence for that is in the two-sided handout that I've distributed. It's an important little document. As you may know, as we'll get to later, the Affordable Care Act, the Obama administration's achievement in health care reform, was questioned and tested at the Supreme Court, and the administration defended its act in this brief presented to the Supreme Court. These are the first few pages of the brief. You can see it in the Supreme Court of the United States, Department of Health and Human Services, and it is represented principally by the Solicitor General of the United States, who at that time was Donald Verrilli. This was the actual document before the Supreme Court. You'll see on the second side there that what the Obama administration appealed to as the first argument before it got into all the complicated legal grounds. This is a brief that runs several hundred pages. They start by saying, the Act in general, that is the Affordable Care Act, and the insurance reforms in particular, culminated a nearly century-long national effort to expand access to health care by making affordable health insurance more widely available. As early as 1912, Theodore Roosevelt called for a system of social insurance to protect against illness and other hazards. And the reference is Anna Emanuel Byrne et al., Struggles for National Health Reform, an article published in the American Journal of Public Health in 2003. What this reference doesn't tell you is that the article by Anna Emanuel Byrne was actually written by 4 authors who were listed in alphabetical order. I was one of the 4. So I'm actually, if not overtly, indirectly cited by the Obama administration in its Supreme Court brief. The article is Byrne, Brown, Fee, and Lear. And so, alphabetically, Anna Emanuel Byrne came first, and she's the only author cited, but you'll actually have a chance to look at the actual article. It's posted on Blackboard, and that is the article that the Obama administration uses to make its first case. They talk about President Franklin Roosevelt, and they talk about President Truman, and then they talk about Medicare, Medicaid under Johnson, and so on. It's a nice little story, but from my point of view as a historian, though I appreciate the reference, the indirect reference, the irony is not lost on me that for a considerable amount of my time and energy in recent years, I have been critiquing the Affordable Care Act, not from the right, but from the left. It doesn't go far enough. It ain't single payer. It's not what Bernie wants. That's what I want too. And I will make the case for that at the appropriate time. But even though I was a critic of the Affordable Care Act, there I am cited by the Obama administration to defend it in the Supreme Court. Okay? Since they at least won half of the case, who knows? Maybe that had some influence on the justices. I don't know. But the history, for all their good intentions, is very, very limited and imperfect. It's a kind of great man history, in which case, in this case, the great men are the presidents. So their history is very spotty. There's much more in the article by Byrne, Brown, Fee, and Lear than they cite, even though it's a rather limited article. It's only about 8 pages or so. It's in the American Journal of Public Health, which has a real premium on journal space and so on. We've got to be very succinct. But even if you had read the full 8 pages, you would not focus on just presidents. Actually, in 1913, Teddy Roosevelt was no longer president. He had been president as a Republican. He broke with the Republican Party and ran as a progressive, head of a new third party, the Bull Moose Party. Didn't win the presidency. The split between the Republicans and Roosevelt followers allowed Woodrow Wilson, the Democrat, to win, et cetera, et cetera. But he was a president, even if not at that moment. And the others cited are clearly presidents, Truman and Franklin Roosevelt, and by implication, Lyndon Johnson and Clinton and so on. It's a president-to-president history, and I think that merely scratches the surface and doesn't give us the real story. We need to fill in a lot of the missing pieces. I think the textbook account on the pages I mentioned before, especially pages 96 to 105, I think I listed about 20 odd pages. There are 9 or 10 pages within that, 96 to 105, that give a pretty reasonable account. But also, the textbook itself is guilty of short shrift. It gets some things wrong. It presents them in what I think is a peculiar and ahistorical order. And so, what I'm going to try to do in lecture, starting now for another minute or two, and then continuing Monday, and then after the midterm when we will resume this story, we're going to go over the same ground as in the textbook, but we're going to use other sources to amplify. We're going to use handouts, and we're going to use readings that have been posted on Blackboard. And I want to start, at least we got to the first page of this handout, so that's an achievement of some sort, of the 9-pager, with this man, Isaac Max Rubinow, who was one of the great pioneers and heroes in the long effort to get national health insurance in the United States. Isaac Max Rubinow was an immigrant from Russia. So obviously you know how dangerous immigrants are. They bring strange ideas like this with them. He was actually a brilliant young man. He grew up in the Lower East Side of New York, which is a teeming tenement neighborhood, just overloaded with immigrants and the challenges of living in tenement house conditions. And yet, he fought his way out of the tenements, got his undergraduate degree at the City College of New York, the Free Academy, known in immigrant communities as the proletarian Harvard. You got it on the basis of your intelligence and your test scores, and tuition was free. And it was right on through the 1960s and into the early 1970s. He then went to what is now called NYU Medical School, where he got his MD. A very intelligent, curious, multilingual man. He also went on to get a PhD at Columbia in what was called political economy, some mixture of what we would now label as economics and political science. He was interested in European social insurance systems. He was the United States' most astute, most informed student of those systems. He was hired by the Department of Commerce of the federal government in about 1908 to go on a study tour and look into all those systems in Belgium and France and England, etc., all those countries which already had well-developed social insurance systems for the Department of Labor, because there's an issue about labor and labor relations, obviously, and produce a monograph that would summarize the main findings and then come out with some recommendations of what could be implemented for the United States. He produced 2 large volumes, each more than 1,000 pages of detailed information and analysis. And he was then able to distill it to make proposals for various social insurance measures, one of the first and most important of which in his mind was to create a national health insurance system. So this man, not Teddy Roosevelt, who used Rubinau's work. Rubinau wrote the plank on health insurance for the Progressive Party platform that Teddy Roosevelt ran on. But he was the guy who investigated, who knew it, who was the brains behind the operation. And if we want to credit anyone as beginning the discussion in the United States of what had already become common in Europe, national health insurance, this is the man, Isaac Max Rubinau. And we're going to have to leave it off at here and resume the story with a quick march on Monday through as much of the history as we can get.